So, as you know, I'm Becki, and I've been a physio for nearly 20 years now, and I've worked with cancer patients for the majority of that time, and across all ages and across most cancers. I've been fortunate enough to train in America, which was quite eye-opening and different, and I brought back wonderful experience from there. And I've also been able to train with one of the leading exercise medicine professors, Robert Newton, from Australia, and I hold the registration with Pink and Steel, which is an international organisation for exercise oncology. As well as being a physio, I'm also trained in nutrition and nutritional therapy, as well as things like Pilates, scar therapy, and acupuncture. So I kind of evolved my practice over the number of years that I've been doing it to provide a really sort of holistic interaction with clients. At Synthesis, where I work, we approach cancer care with an integrative oncology mindset. And that involves a doctor-led multidisciplinary team. And that delivers personalised care for adults affected by cancer throughout the UK. I'm guessing most of you are kind of Berkshire-based. Myself, I live in Gloucestershire, but I come and work outside of Reading at the Synthesis Clinic, and we do one-to-one and group care there. So today, I'm really going to talk about exercise in cancer care, not just as a wellness extra, but as a clinically validated therapy with direct impact on survival and quality of life. So why does exercise matter? Exercise improves treatment outcomes, and it reduces the recurrence rate and enhances quality of life across all cancer and care phases. Is what we want, and what I want to in this population that I see. So today we're going to cover the benefits, guidelines and safety, mechanisms of action, practical implementations, and the role of the expert. So this is interesting, and sometimes it's quite eye-opening for patients that I work with. The World Health Organization defines physical activity as any body movement produced by the skeletal muscles that requires energy expenditure. And that physical activity should not be interchangeably used with exercise. Exercise is a subcategory of physical activity that is planned, structured, repetitive, and purposeful. In that sense, the improvement or maintenance of one or more components of physical fitness and health is the objective. And that's what really I sort of engage with patients on that, because often people will feel that they've done a walk and they will feel that they've met their goals for exercise that day. And I try to encourage people to think of exercise as a really structured part of movement. It's not quite the same as physical activity, like your housework and things like that, which is all physical activity. Exercise has to become more structured and purposeful. So this slide's a bit busy. Hopefully you can see it all okay. So why exercise matters in oncology? And that's because it matters throughout the continuum of care. Exercise improves how patients feel and their survival outcomes. It supports treatment efficacy and long-term recovery, making it clinically comparable to some pharmacological interventions. It can be used as a neoadjuvant treatment, so getting people ready to engage in treatment or engage in surgery, getting you to be more resilient before you take on this journey. And that's a really important phase to get going in if possible. Adjuvant during treatment, well, it's there to support efficacy of treatment and to manage the side effects. And it's really potent in that phase, and it's often the phase that people struggle the most with. Rehab, post-treatment, post-surgery, we all know where physio fits in that picture, but it's really important to maintain, if not progress in that part if possible. Survivorship, we're there to help manage any side effects, as well as keep in mind about disease prevention later on, as well as looking to support people in palliation and keeping life as good as possible in that phase. So it really does span the whole course of the continuum of cancer, and it's something that once you take on board as a medicine, you really take it into your sort of toolbox of how to manage the disease. So this slide may be a little bit gobbledygook to a lot of people. It's the mechanisms of why exercise is important. It's important because if our own body is able to produce in medicine in our body, and it's called endogenous medicine, and I'll refer to that throughout the talk. But our body is like a great big pharmacy on its own, and if we can give it the stimuli to produce these mechanisms, then the tumour environment can change. So if we exercise, we can create immune modulation by sort of immobilising natural killer cells. These killer cells, through exercise, are able to travel to the tumour and have been shown in the Pedersen paper, which was a preclinical paper, to helping change the tumour environment. It also has an anti-inflammatory role by reducing IL-6 and TFN and CRP, which you might all be familiar with as a marker of inflammation. it can increase the delivery of chemotherapy to the tumours, which is really important if we're thinking about really getting the most out of treatment as possible. If we move our muscle, we get these myokines released, and they also create anti-tumour activity. And as well as having epigenetics changes, it can modify genes. So exercise must be dosed and monitored like medicine if we're thinking about our body as its own natural pharmacy. So I hope you can all see this slide, okay? It's a new infographic that's been released. It's kind of like an exercise food plate, if anybody's familiar with that. Just if you have a look at that for a second or two. So these guidelines reflect the consensus from ASCO as well as UK bodies. And really what they're saying is don't take cancer lying down. Little activity is better than none. To sum them up though, really, what they recommend is 150 minutes of moderate intensity aerobic exercise and 2 strength training sessions per week with consideration for flexibility and balance. And you've probably all heard of these over the course of time because they also span across multiple diseases. So they're not really specific to the client population that we're talking about today because it doesn't take into account anybody's stage of cancer or perhaps their treatments or anything along those lines. These can be aspirational for some people coming into exercise. 150 minutes of exercise can be mind-boggling for some, but that's where it's really important that these are guidelines and not something you have to take as rigid. They can be built up to. So when I think of exercise, there's the principles that I have to think about before I start writing any prescription. This diagram illustrates the core principles that underlie effective exercise programming. Centre, we have exercise principles, the foundation of designing a safe, effective and goal-orientated fitness plan. And each of the surrounding bubbles represents a key concept, and we'll go through these in a bit more detail throughout the presentation. So the principles of exercise prescription, it can be sort of nailed down to 5 things, but we'll expand it again as we go through. But overload principle you may have heard of, as well as progression, specificity, individualization, and reversibility. So I'm guessing you've all heard of the 2 modes of exercise. One's aerobic, such as this gentleman in the corner, running, cycling, jogging, those type of things. And then we've got resistance training, which this young lady in the other corner is doing. So it could be with weights, it could be body weight exercises, resistance bands. It's anything that's really targeting the neuromuscular musculoskeletal systems. So what is aerobic exercise? Well, aerobic exercise stresses the cardiorespiratory system. I'm sure you've all had a run and got out of puff, and that's what we look to train. We're asking the body to increase its heart rate, its blood pressure, its respiration rates, and to provide sufficient oxygen to the working muscles, and then get rid of that carbon dioxide. And what we do when we really sort of target aerobic exercises, we're really trying to work those big muscle groups repetitively over an extended period of time. And that's why it's usually things like walking, cycling, swimming that spring to mind when we're thinking of aerobic exercise. And in this population, there's 2 categories really that I'd focus in on. One would be moderate intensity continuous training, and the other one would be HIIT training, which you've probably all heard of before. So aerobic considerations. Now, we don't want everybody to be exercising flat out for 150 minutes, if we can help it. I don't even think I can do that. So what we look to do is work at 60 to 80% of our heart rate max. And we do that with a calculation. So as you come on board into clinic or into the exercise centre, we'd do this formula for you to target the correct heart rate zone that we'd want people to do their aerobic exercise in. So for this 45-year-old lady, or gentleman, it could be that we'd be looking to target zones at 106 to 142 beats per minute. So that might be when you're thinking of walking out in the park, it shows you that you may need to up your pace to what you've been doing normally, because that is going to help your pharmacy, your own body pharmacy, to start moving, start all these mechanisms acting and getting all that endogenous, so that inside medication flowing around the body. A good place to start is 20 minutes if you're new to exercise, but we're gradually going to be wanting to increase that fairly quickly to get you up to 30 minutes of aerobic exercise. For some people, their weight loss goal is a big goal for them, but actually exercise is not great for weight loss, no matter what people think. It takes a lot of energy expenditure to have an effect on weight loss, and they say about 300 plus minutes for that. And that's a lot of training, especially if you have to factor in things around appointments and childcare and work, all those things. So HIIT. I can't see your screens because I'm looking at my slides. But HIIT, when I say to my patients, we're going to incorporate some HIIT into our sessions now, their faces look horrified. I think because a lot of people think of exercise programs like Joe Wicks, and they think, oh my gosh, that isn't for me. And that's really, really understandable because they are hard work. I mean, from the infographic, we'd be wanting you to work in the red and orange sector, definitely sort of 14, 15, 16. And if you can, a little bit above that. Again, that's because we're trying to tap into that body medicine and really get it flowing. And evidence suggests that the more we tap into this higher energy expenditure, the more those mechanisms work. HIIT exercise is fantastic for people who are short on time because it's quite a time efficient way to exercise and get those adaptations. It's normally done in a work to rest ratio, and it really does target the energy system, and it has great effects on endocrine and metabolic adaptations. But again, it's something that you work up to. Hardly anybody who I see in clinic are athletes before they come to see me. So we have to start where an individual is ready to exercise. It's usually safe and well tolerated, especially if it's done under supervision. HIIT is great for across the board of conditions usually, and particularly good for cancer and cancer recovery. It can be adapted quite easily, and this is a great way to get bang for your buck if you're really short of time, is to add some resistance training into your HIIT. And you might see it written in some places, it's HIRT. But usually a HIIT can be done something as simple as this. So a 5-minute warm-up, and your sets could be sort of a 30-second all-out workout, and you'd rest for 1 minute, and you'd for maybe 8 rounds, and then you'd do a 5-minute cool down. So you can see you can work really efficiently to keep that tap dripping of those medicines in a really short space of time. Again, I can't see how many people here, but if I asked you to put your hands up, how many of you are doing resistance training already? I hope everybody's hands up, but it'd be interesting to watch this back and see how many of you put your hands up. So dynamic, concentric and eccentric muscle contractions against resistance is what's termed as resistance training. Now, resistance training doesn't have to be going to the gym and hitting really big reps in the free weight section. It can be done controlled in the gym environment with machines like you can see in the corner, but it can also be done with resistance bands as well as body weights. Usually, if we're working towards a goal, a program of 6 to 12 repetitions is generally my range that I might prescribe into, depending on somebody's goal. I'd always want to make sure, particularly in the cancer population, that they weren't going to failure, which means that you're not lifting a weight so heavy that you could only do it sort of once. We'd want you to be able to lift a weight that you could do comfortably for how many sets, but on the last 2 to 3 repetitions, that was sufficiently hard enough and you couldn't do any more. So you had some reserve left. And sometimes working with a trainer is the best way to find that out, because it can sound quite complicated if you're not familiar with that. I love to program 48 hours recovery between muscles, the muscle groups worked, because I think it's really important, and we'll discuss it later on for why. It's best to target large muscle groups that are functional in movement, because you're getting bang for your buck. We're getting more stimulation of those mechanical mechanisms that are happening in your body. And they're usually the big muscles that work over different joints to really keep us functional as we progress through our treatment, but also as we progress through years and into survivorship and things. Sometimes the sessions can be done twice a week. If we were doing that, it might be a full body program done appropriately with appropriate rest, or you could split it into different sessions, such as an upper body session a couple of times a week and a lower body a couple of sessions per week. And we really just want to target muscle groups that we feel are becoming a little bit deconditioned by treatment. So I'm going to kind of talk about now what goes on in my mind when I'm writing somebody an exercise prescription. And that refers to quite a few principles that I have to think about as we go through it. So I'm guessing for all of you that do weight training, you've heard of the overload principle, and that refers to performing exercises to which the body is not accustomed to. So it may be that you're able to lift your Sainsbury's shopping out of the car and say that weighed 3 kilograms, and you've been doing that for the last 5 years, but suddenly you buy something from Sainsbury's and your shopping this time is 5 kilograms. You might feel it the next day or the day too, because your muscles haven't become accustomed to it. And that's a little bit of a progressive overload. We can change it in many ways. It could be, for instance, that you were only able to cover half a flight of stairs. You could overload that by doing the whole staircase. It could be that you're only able to walk to the end of your road, but by doing a progressive overload, you might be able to walk around the block. So there's lots of different variables. It doesn't just have to be putting on the kgs to a weight. There's lots of different parameters we can manipulate. So this is a one that you might also be familiar with. It's called the adaptation principle. So as you can see from the gentleman in the corner who was carrying his ox, I'm guessing, to work like you do every day back then, as his ox got bigger, so did he. And at the very end, you could see he had changed quite significantly too, but so had the ox. And that's because his system adapted because he was overloading himself. And that's basically what the adaptation principle is. And that's what we want to happen with our muscle systems. We either want to maintain, or if we're going through treatment, we want to try and maintain and keep them growing as much as possible because they can become deconditioned. The next thing about writing a prescription of exercise for somebody is we have to make it specific. There's no point me asking a sprinter to go off and do rock climbing, for instance. It has to be something that somebody's really genuinely wants to train in, whether that's just so that they can manage activities at home a bit better, go and play with the grandchildren, manage better at work. We have to really focus in on what's important in people, and that makes it more holistic. It makes it meaningful to them, and that really helps with goal driving. And we want to make the kits specific too, because we want to use energy systems. We want to really utilise them because they're important going forward in treatment for that resilience that you need. The muscles that need to be activated for the specific tasks need to be factored in. What type of contraction? Is it something that you're holding above your head for 10 minutes a day? Well, we need to focus on holding that contraction. That would need to be incorporated into the programme. Or is it a specific pattern that somebody wants to be able to do? And when I say pattern of movement, it is like getting in and out of a chair or in and out of a car. These all take skills. And if it's something that you're really struggling with, that's what you need to put in place and practice, as well as making sure the tissues are loaded as we go through. The SAD principle, again, some of you may or may not be familiar with this one, but it's important to have it in the back of your mind because if you're working with somebody, you need to know that they've considered this. It's especially important when working with cancer patients, as the overload must be appropriately targeted to the health issue which is being addressed. So perhaps there may be bone compromise, or you might have muscle deconditioning from treatment. We'd want to make sure that the specific adaptation that is asked for you to be doing is appropriate. So this is another one we discussed briefly about, is individuality. Again, that's taking into account specific needs and abilities of an individual. So I could have 3 breast cancer ladies sat in front of me and they would all be very different. I couldn't write the same prescription for every single one and just have a bog standard protocol. It doesn't work. Things that need to be taken into account is things like prior training, exercise history, health history, medical history, and that genetic makeup of the individual. The training adaptation to a given overload will be specific to that individual. So that's one thing I would want you to take away today, is we're probably not going to leave this session with me giving you an exercise set prescription. This is what you need to go away and do, because when I work with somebody, it needs to be really individualized, and that's where we get into precision exercise prescribing. Trainability. So this is also interesting when we're thinking about writing up exercises for some people. Some people respond great to exercise, some people don't, and it's one of those things. It can be behavioral, can be treatment related, but it also comes down to previous exercise history, any illnesses, again, stages of cancer, and any other illnesses that you may have had. Again, what I necessarily think somebody should be able to do may not be what they're able to do. And I have to be flexible and accommodating in what I say and see to the person that's in front of me. Now, this is the one that's also a bit sort of frustrating, because we've all started an exercise program brilliantly, and we've gone for health and ever, and it's going great, 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 great. And all of a sudden, you're still doing the same thing, but you're not quite getting your gains that you used to. So you're not really progressing on your 5K time, or you're stuck at the same kgs that you're lifting, or you're swimming, you're not going improving stroke rate or anything like that in the pool. And that's because we get this period of diminished returns. But to counteract that diminished return, we need a greater overload stimulus. And that's why it's really important to not be given just a program that says, go away, do 10 lots of exercises 3 times a day, without the guidance of how do I progress that, because it's not going to serve you very well. Because of this principle of diminished returns, you need to be continuously creating that greater overload to keep getting the effects that you're after, and to keep getting that activation of that endogenous medicine that your bodies can provide you. Because it sort of titrates down, because our body becomes so used to it, it feels it doesn't have to work so hard. So we keep having to challenge ourselves. The one thing is, sometimes it's important to also realise that more training is not always better. It has to be, again, that structured, purposeful and appropriate training to get the goals that people are wanting when they're exercising. So we do have a window of adaptation when we exercise, and it does get a bit smaller, and that runs back to the diminishing returns. But for those who haven't exercised before, the training window is usually much better. You can get a great big curve of improved exercise tolerance from somebody that hasn't exercised for a while compared to somebody who's done a lot of exercise. So this gentleman in the corner, unfortunately, he has had perhaps a prescription from somebody whose exercise plan was go and do these exercises, 10 repetitions for 3 times. And he hasn't been given clear guidance, and he's been doing the same exercise prescription for 3 years. And what you can see from the picture is he hasn't made any real physical change from what I can see in the picture. You may feel slightly different, but from my perception, he hasn't made great change. And that's because he's only really put the minimum intensity into his training program, not because he's not trying hard, but because his body hasn't been giving that stimulus to change. And what we're trying to do is create the sufficient disturbance of homeostasis to drive the signaling within our cells and tissue systems to adapt and change and give us growth. I mentioned earlier about how important rest and recovery is. And the reason why rest and recovery is so important is because it's not when we're exercising that magic happens, it's when we finish exercising, giving ourselves that opportunity to recover and to grow. So when someone writes you an exercise program or a prescription, or you're working with a trainer, a Pilates teacher, or anybody like that, and you're doing it repeatedly, reliably, and consistency, what I find is a lot of people in clinic, they feel that if they don't exercise every single day, they're not doing what they feel is best for themselves. But actually, it's counterintuitive to overtrain. It doesn't serve you very well because it's not going to give your muscles enough opportunity to recover. And what happens is, if you're constantly draining those muscles, you're also constantly kind of draining that endogenous mechanism because it can't be topped back up, which is what you'd get with rest and recovery. So you want those muscles to fill back up and then fill those mechanisms of exercise again. And things to take on board in this phase is that rest is good for you. It will help manage fatigue to a degree, although we'll talk about managing fatigue a bit differently later on. But sometimes we just have to listen to ourselves as well. And treatment is going to slow down recovery in our cells and our tissues, so we have to factor that in. Sometimes it's not just resting for 2 to 3 days that I might write a prescription up for. It can be that some individuals come back and tell me that I'm still not feeling rested and recovered by day 3 and 4, and then we change the prescription to suit the needs at the time. It will also help with that delayed muscle soreness that some people can get with exercising if they're new to it. This is one of my frustrations with exercise. I'm the same when I'm exercising too. And it's important to remember that the changes that we make with our fitness, whether that's getting cardiovascularly fit or stronger, aren't permanent. And that's really hard because we work sometimes so hard to get to these points, and then a holiday might come up or a spell in hospital, and unfortunately we can get a bit of reversal come in. It can be that for those who are more highly developed and have been exercising for a longer time, if you have a break from exercise, the adaptation is retained to a degree. And then again, if you tamper that down a little bit, doing a little bit of something again will help minimize a reversal to a degree. But again, that downwards curve would still happen. And then if we became immobilized or in bed rest, for instance, which some of our patients unfortunately are, then that detraining and deconditioning comes back in. And then it's much harder for somebody to take their exercise back up, rather than if they'd maintained it at the same level. And if they're starting back down here, it's just a much higher hill to climb. And sometimes that's really hard, physically and mentally. So maintenance is always a good one to consider, especially in the treatment phase. Some of you, I don't know if any of you have, and I can't see you in the background, might have done a Couch to 5K program, and you'll know that the program's quite tough, and you have to work, say, maybe 3 to 4 days of the week, and that's fine, and you've hit your goal and you've done it. Now you're like, what do I do? And some people will go on to train and do 10K marathons. Amazing. Then some people will kind of just teeter and not do so much. And it's those who maybe train for 1 to 2 sessions a week will actually maintain their fitness. And that's probably a really good thing to have in that treatment phase. If we aim for maintenance rather than becoming deconditioned, because that means there's a less of a hill to climb, which I find serves patients much better than allowing the sort of significant deconditioning to occur. So variation is a good thing to keep up exercise engagement. This poor lady in the corner who's been doing a million press-ups in a million different ways, but she's still going because she's got variation in her exercise prescription. And we know we're still going to be getting the same training stimulus and the same muscle adaptations and all those things we've discussed before, but it keeps you engaged in exercise, and that's really important. So if you are working with somebody, ask them, okay, I've been doing a squat. Can you give me 4 different variations of a squat? And just to keep you really engaged in that exercise. This is quite nice to know, though, if you've got lines in or a pick in or something along those lines. You can get cross transfer of changes within the musculoskeletal neuro systems. And that's principally due to neuroadaptations, as well as hormone and cytokine signaling. So if you're exercising one arm, perhaps, that doesn't have a line in, there is some crossover in the opposite arm. So it doesn't have to be perfect. It doesn't have to be symmetrical. It just has to be consistent. Now, when I'm writing a prescription, it depends on somebody's goal. And this is a bit more for those who are interested in strength and conditioning. But sometimes aerobic exercise can be counterintuitive if I'm asking somebody to go on a real big strengthening phase. But that's not for the majority of the cancer patients that I see. It's mainly multimodal prescriptions that I would write up because it gives you a really good foundation of health. Initial level of fitness, as we all know, it varies I expect every single person on this call today, and certainly for me, and that varies throughout the time of the year as well, and week to week, definitely for me, depending on my family commitments, etc. But it's nice to know that if you're coming new into exercises, you should get to see some lovely goal attainment and feel really good from exercising. There is a ceiling for some people. Again, that's those who are coming in from an elite fitness component. I'm not one of these people. I've never hit my ceiling of exercise capacity, but it is there, and it's usually determined by genetics. But saying that, I have worked with a few athletes, and they are very, very inspiring. There is a difference between males and females. Due to contrast in hormone profiles, really, and in particular the effects of testosterone. Aerobic fitness is generally the same between both men and women, but men tend to adapt strength-wise to a greater degree than females. I don't think that's a surprise to anybody. Age, obviously, that can affect training as well. But older people can exercise really, really well and really, really effectively. And it shouldn't be not referred to because of somebody's age. The dose would be something that your exercise prescriber will take care of for you, because it's going to matter on your goals, your treatment, and what you're trying to achieve. But you should work with somebody and ask them to discuss that with you. We know that the exercise sessions are generally a warm-up, cool down, with a little bit of exercise in the middle somewhere, and there's usually a stretching component to it too. Generally, this is a sound principle to stick to. There are some physiological as well as psychological reasons underpinning this design, and I would suggest that you stick to it if you're going to do anything independently. Warm-up, as you know, the purpose is to increase temperature, blood flow into the muscle and the connective tissues, and it's really good to get that synovial fluid within the joints, and it helps you mentally prepare for what's coming next. Intensity should be gradually increased to warm up your heart rate and your blood pressure. So treat the warm up as something considerate and kind to yourself as you start to implement one. But generally, you're thinking of something for a 5 to 10 duration, something that's light load, maybe some static and dynamic stretches in there for some people, especially if they haven't moved for a long time. But it would generally be low intensity. The conditioning phase, my favourite phase for everybody, of course, is where we get to work hard and achieve our goals. And this is where the magic really happens when we're thinking about exercise oncology in integrative care. The cool down, as we know, is there to gradually transition from high intensity to exercise at rest. This can be a lovely phase for those who are new to exercise, really letting our nervous system calm down after exercise. But it's important to help mobilise that lactic acid and lower blood pressure and heart rates gradually. And it just helps reduce any risk of cardiovascular compromise or any adverse events. Stretching. Often I get asked about stretching. What should I do? It's there. I think it's a useful thing to have at the end of the session, but I would not count it as an exercise. I would use it as something to make you feel a little bit more mobile. But it's something to consider. And when we think about how long we're going to train for, generally I'd write a program for 12 weeks. Because our body does take that long to adjust and develop, really, especially when we're working with a population that may not be well at times, maybe battling fatigue, and may have nausea, sickness. They might be bouncing in and out of hospital with temperatures and things. So periodization is important in an exercise prescription. So making sure that it fits across somebody's needs is really important. And it can be periodized around treatment. So if you were to have a treatment break, for instance, you could work really hard with somebody at that point of time to really condition your body and get it in the best performance it possibly can before you restart treatment. And it might be that your prescriptions for those two phases are very different. It may be that the chemo phase, we're asking for maintenance of what you've tried to work so hard in that treatment break phase, or something along those lines. But it's important to understand that training doesn't have to be the same every single training session, every single day, every stage of cancer management. It needs to be appropriate to what the individual requires. Autoregulation is my favourite thing that I teach to patients all the time. Now, I know I can say to somebody, go away and do 50 squats to me, for instance. Now, 50 squats can be done very, very differently. It can be that they can be done very fast and you may be working very hard cardiorespiratory, or they might be done very slow because you're feeling fatigued. And that's how you auto-regulate. You kind of set your own pace and things to how the body's behaving for you on that day. But it's important with the cancer and cancer journey experience to be able to recognize that you're not going to be the same at every single training session, every single exercise, because you need to auto-regulate. Bone health is something people also come to me for. As we know, therapies can affect our bone health. For most patients, resistance training for muscle hypertrophy, so growing our muscles, and for strength training will provide bone density benefits. For those with disease or treatments that can cause bone loss, such as hormone therapies, they may need extra training on top of that. Bone responds to rapid changes in force, and impact loading has been demonstrated to have safe and effective outcomes if implemented correctly, but this requires a strength base first. I never work with somebody straight off the bat on a bone health program. I want them to have a good strength base first before we even try skipping, jumping, or anything along those lines. So I'd usually run a 12-week strength and conditioning phase and then run into a protocol, for instance, where I would then incorporate things such as marching, hill drops, jumping in place, skipping, hopping, those types of things, all the way to bounding, because our bones respond brilliantly to impact once it's done safely. So I see a lot of people with advanced disease. One of the biggest concerns when prescribing exercise, whether it's done face-to-face or online, are individuals with bone metastatic disease. Often, and it has been a long time, that these patients may not be referred for exercise because of adverse complications of their disease. That doesn't hold up in the evidence anymore, and everybody should be exercising, even with bone metastases. There are protocols in place that should be followed, and there are exercises that you should and shouldn't do, but everybody should and should be exercising, even with advanced disease. Lymphoma is another. Lymphedema is another one that patients present with or are concerned with before they start exercising, because maybe their nurse has said to them now that they shouldn't exercise because you're at risk of lymphedema. But resistance training is safe and efficacious for people with or at risk of lymphedema. In fact, the ladies and gentlemen who I see, I get them to lift heavy, and it would be, a good set weight for 6 to 12 reps, not light weights, because we're wanting our body, our muscle system, to pump that lymph fluid back up where it belongs. That's what our muscles are there for to do now. Provide that pump, which could be affected by lymph node involvement. So don't be afraid to exercise if you've got lymphedema. There's plenty of people out there who are trained in this who can support you, but the evidence suggests that you need to exercise. Other symptoms that I often get referred to for are nausea and vomiting, because exercise really does help with things like supporting digestion, reducing stress, and improving mood. It helps balance neurotransmitters, which can be really important if you're experiencing low mood, as well as improving overall well-being. And there's a heap of evidence out there to support symptom control with exercise. Fatigue is one of the barriers that I come up against the most. There's a stack of evidence out there to suggest that cancer-related fatigue can benefit from exercise. It's different to other forms of fatigue, and it's different to being tired. But cancer-specific fatigue can be really helped with aerobic exercise, even better helped with a combination of exercise of aerobic and resistance training, dovetailed with some of the relaxing work like breath work or yoga or sort of like Reiki, those type of things. But it's there. It's often one of the things that pulls people out of exercise or stops them participating. But if you can work through that barrier, it would serve you really, really well. Of course, there's a risk with exercise, but I work under the Hippocratic Oath and I try to do no harm. I think exercise medicine is good for everybody if it's done with wisdom behind it. There's usually very minimal risk, even though it's there, but adverse events, sort of grade 3 and above, are extremely, extremely rare. There's some contraindications that I would screen for before coming into clinic, and they are mainly around heart conditions and significant respiratory conditions, but they would be flagged up before you came into clinic. There's relative contraindications, and these are the ones that you would exercise caution with, but should still be able to exercise with. And again, your person who you're working with should screen for these and write up your prescription accordingly. And here's just a few more. But again, these shouldn't sort of exclude you from exercise. If you're not being referred to it for any of these reasons, ask them to why, and could it be explored? So generally, most people want to reduce fatigue, get stronger, and maintain function. So prescription could be something along these lines. This is just it in a very, very small nutshell. How do you start? We start off small. 10 to 15 minutes of aerobic exercise, building up as much as you can. You start with weights that you feel comfortable with. It's okay me saying you need to be heavy and really challenge your system, but if you're not confident to pick up a small weight, start at the weight that you're confident with, because strength will grow from confidence. You can modify exercise as much as you need to. And if you're struggling, the biggest thing I would recommend would be working with somebody who's skilled in this area, because having that what's the word I'm thinking of? Having that somebody that you have to go to can create a habit that becomes something you can do independently. Challenge trial, I'm guessing you have all heard of that. I can't do an exercise presentation at the moment without it. Fabulous trial for exercise oncology. You would have heard how exercise now is blown up in the cancer community with this study, basically showing that it has fantastic benefits if done in a structured way. It's been shown to have, reduce cancer recurrence by 28% and increase 5-year survival. This one was only with colon cancer patients, but there are other exercise trials coming out. This one was with breast cancer, showing the same things. Exercise is really important in your toolbox for managing your health now and later on. Working with somebody who is experienced, I can't sort of stress enough, because they would be able to screen for those complications for you, as well as consider cardiotoxicity and other complications. They will be able to adapt exercises around things like ports and lines and things, and they would be able to bridge that acute oncology care to long-term survivorship. Because when we work with people, we often think about how they are in this minute in time. Also, we need to think about how they're going to be in a longer period of time as well, especially if you're working with the children, paediatric community as well. That's an important consideration. So these are my sort of final thoughts, really. Exercise is still encouraged, even if you have ports and picks and things in situ, and you just need to modify and don't stop. Tailor to the condition, use assistive strategies if you need to, and monitor progress gradually. If you came into me in clinic, this is exactly what we'd do. We'd provide a comprehensive assessment, you'd identify and prioritise health concerns, we'd get to understand your capacity and suitability. I'd write you an exercise prescription, and then we would do anything that needed to be monitored, and then we continuously reassess and modify. We'd do loads of outcome measures to give you something to work towards and get those goals that you set out to achieve. I'm not the only person here that does that. There's lots of people around the UK that does exercise in cancer, but these are some of the useful apps and support services out there too. Onkyo app is free. It's a brilliant app. It's an integrative oncology app too. So there's loads of support on there for lots of different things. There's star therapy on there, there's breath work, there's yoga, there's lots of different things, and it's really fantastic. It's designed by NHS clinicians with patients in mind, and do check it out. Like I say, it's free. It's really, really useful. And there's things like NHS services, there's Macmillan, there's Cam Rehab, of course, there's Pink and Steel, as I mentioned earlier, there's Maggie's. I'm not sure if any of you are familiar with Penny Bron. I suspect most of you are. There's a new charity just being launched called NCIO, which is a National Centre for Integrative Oncology, which may be useful going forward. There's lots of paediatric resources out there. So really, to summarise, exercise is a clinically validated therapy targeting inflammation, immunity and vascularisation. It improves treatment resilience, which is so important to keep that treatment regime going for as long as we possibly can. Survival, of course, and it also reduces the recurrences. It is very safe when supervised, and it's still safe if done alone, if you've got an understanding of what underpins safe exercise. So my leaving thoughts for you today is consider exercise as essential as your medicine. So the end slide just has a few of my references, but that's really it, and I'm open for questions.
Thank you very much, Becca. That's extremely comprehensive. And I'm sure that there will be some questions. So has anyone got any questions with regard to what they've just seen and heard at all?
I have a question just in general, Becki. I've had a brief look at the Synthesis website and things like that, and it's an integrated kind of wellness element as well. As somebody that's coming towards the end of chemo, about to go for surgery, I'm kind of keen to do overall wellness after all of this to make sure I get the best kind of recovery. I already do weights 3 to 4 times a week, Pilates and swimming. So the exercise side of it isn't too much for me, but I'm just curious about, because I have a port of what I can do. I've avoided upper body things like that. So would you suggest coming to the clinic? What would you or would you say go and find a PT? Just that one-to-one, really.
Definitely, if it's one-to-one training, then coming into the clinic is the best way. I think when people have ports and lines in situ, often the confidence of exercising is quite low, and especially if you've not been really challenging your upper body. So really working with somebody, whether it's me in clinic or somebody else, it would be the best way forward, because there's so many variations of how to target what you're trying to target with your upper body. That, you know, it's better done whether it's on Zoom or in person. You can definitely exercise with a port in your upper body.
Okay. And would you say kind of having that nutritional side of it as well to support the exercises are a good thing to do through Synthesis? I don't know too much about that bit.
Yeah, definitely. So 100% so, because I feel training and exercise go together. And I think from a cancer journey perspective, nutrition is key too. It can really be a supportive tool in your toolbox. Working with a nutritional therapist who understands bloods, what we're trying to achieve, we're making them optimal. Because there's some things, if you've got a high inflammation load, or perhaps you're low in vitamin D or something along those lines, can make life much more of a struggle for you than it needs to be if it's not being managed and optimized, whether that's through food first approach or supplementation. But definitely, I would say if that is a area that you would want support with, then I would see a nutritional therapist, whether that's at Synthesis Clinic or not, because they will really support you now that you're coming into surgery, because you need to recover well from surgery, and nutrition is a key part of that. But also coming out the other side of surgery, making you as well as you possibly can be, nutrition is going to be key to that too. Yeah.
Okay.